Greetings to all. My name is Dr. Mpumelelo Nyathi from Sefako Makgatho Sciences University in Pretoria, South Africa. Today I'm going to give a presentation that goes by the title Pediatric Diagnostic Nuclear Medicine Studies and Administered Radiopharmaceutical Activities at a Tertiary Hospital, a contrast with activities based on the European Association of Nuclear Medicine, Dosage Card version 5.7.2016. For interest's sake, let's start by looking at the significance of nuclear medicine imaging. Nuclear medicine imaging provides potential life-saving information regarding physiological and molecular processes. Nuclear medicine studies are minimally invasive yet highly sensitive. They permit early detection of diseased organs before any structural changes occur. Furthermore, they play a significant role in patient management and decisions as well as therapeutic decisions. At this juncture, let's pause and focus on Figure 1. A pediatric patient lies still during imaging. In order for this to happen, sometimes the mother needs to be present because the child might not agree to lie still during the imaging period. Pediatric nuclear medicine imaging plays a significant role in children and infants, where rapid and equivocal diagnosis of the development or pathological concern is essential for the health of these pediatric patients. The advantage of nuclear medicine imaging is that it relies on the tracer principle. The tracer principle involves administering radiopharmaceuticals in small quantities. Small quantities of radiopharmaceuticals are harmless and do not normally present any allergies or reactions. Let's also now pause a little bit again and focus on Figure 2. In this figure, we have pediatric patients of varying ages. These patients can be classified into 4 categories. The first being neonates with age up to 1 month, then infants with age 2 years, less than 2 years but greater than 1 month, and children with age from 2 to 12 years, and then adolescent with age less than 18 years but greater than 12 years. Pediatric patients may vary in weight from a tame infant who weighs as little as 12.5 kg to a teenage patient who weighs the same as a young adult. Let's now proceed to talk about pediatric radiopharmaceutical activities. Pediatric administered activities should be specific to the child's size and age, as seen in Figure 3. Pediatric administered activities are influenced by varying combinations of tradition, existing dosage schedules, age of available equipment, practitioners' experience, and adult activity in some instances. However, there are issues of concern with regards to administration of radiopharmaceutical activities in pediatric patients. Diagnostic nuclear medicine, although based on tracer quantities of radiopharmaceutical, raises the following concern. The activity administered into the body decays emitting gamma rays, X-rays, and positrons. Gamma rays, X-rays, and positrons are low-dose ionizing radiation. Low-dose ionizing radiation may damage the DNA by either indirect or direct action, as shown in Figure 4. Indirect action. Passage of ionizing radiation in the body may lead to formation of hydroxyl and highly reactive radicals due to hydrolysis of water molecules in the cell. The hydroxyls and radicals have the potential to diffuse and damage cellular molecules despite their short lifespan, which may range from 10 to the -7 to 10 to the -5 seconds. In case of direct action, we will realize that upon absorption by the cell, ionizing radiation deposits energy along its path, leading to atomic ionization. The ions have the potential of damaging biological molecular structures. Other parts of the cell that are prone to ionizing radiation include protons, lipids, and metabolites, which may be modified. Pediatric patients have fast-growing cells, rapidly undergoing mitosis at a higher rate, hence they are more susceptible to late radiation effects compared to adults. Dosing pediatric patients therefore requires optimization of administered activity, a complex process of risk versus benefit. Now let us proceed to look at pediatric radiopharmaceutical dosimetry. Pediatric radiopharmaceutical dosimetry varies considerably from institution to institution and has for a long time been general based on recommended adult dose adjusted by body mass using the formulae administered activity equals to dose formula multiplied by adult dose. There are about 5 existing formulas that have been used or are still being used for calculating pediatric radiopharmaceutical activities. The first one is the Young's rule, which is used for children aged from 1 to 12 years. The advantage of this formula is that it can be helpful when the weight is unknown. However, the disadvantage is that it cannot be used for newborns. Again, the other issue is that there has to be consideration for growth variability in any given age group. Then the second one is the Webster formula. You realize it is a modification of Young's rule. Clark's rule is recommended for older children as Webster formula tends to overestimate the dosage for this group of children. The third formula is Clark's rule. This is based on weight. It's for children whose age ranges from 1 to 12 years. The disadvantage is that it may lead to underestimation of calculated dose due to the fact that the ratio of organ to body weights in infants are greater compared to those of the same organs for adults. Then the fourth one is the Freight rule. This is useful for children less than 1 year. It is also age-based formula. The fifth one is the BSA formula, which is also very helpful. The advantage of the BSA formula is that physiological function and organ growth conform to it closely than the body weight. Again, it provides a good guide for children over 1 year. Furthermore, it provides optimum dosage and better quality compared to that of adjusted body weight, which result in underestimation of dosage, leading to lower absorption and longer imaging time. In addition to these formulas, the European Association of Nuclear Medicine Dosage Card version 5.7.2016 can be used. This dosage card is presented in Table 1. When using this dosage card, the pediatric activity is calculated using the formula baseline activity multiplied by multiple. The dosage card places radiopharmaceuticals in 3 clusters A, B, and C. Sometimes these are also referred to as classes. Each radiopharmaceutical presented in Table 2 is characterized by a corresponding minimum activity and a baseline activity scaled down by body weight as shown in Table 1. The minimum activity takes into account the sensitivity of equipment, the type and duration of examination. For those who would like to have a complete picture of the Table 2, it can be found in the website below. For interest's sake, let's calculate the optimum activity for technetium-99 Mk3 required for imaging of 2 patients aged 20 months and 3 months with respective weights of 12 kg and 4 kg using the European Association of Nuclear Medicine Dosage Card version 5.7.2016. For patient 1, we will need to have the following crucial information in order to calculate the patient activity. Technetium-99 falls under class A. This information is available in our Table 2. Then we check the multiple for the 12 kg patient, which is going to be 12.1 in the dosage card. And then in Table 2, we also check the baseline activity. For the purpose of this calculation, we realize it is 11.9. And then we also can observe from the same table that the minimum recommended activity is 15 megabecquerels. Then with this information, we substitute into the formula for calculating activity for the pediatric patient, which is activity equals to baseline activity multiplied by multiple, we then obtain 26 megabecquerels. Note that in this particular case, we need to administer 26 megabecquerels for this patient. Similarly, for patient 2, we also need to look at the crucial information that we need in order to calculate the required administered activity. We tend to observe that we still can use more or less similar data. Technetium 99 Meg 3 falls under class A, and the corresponding marble for this 4 kg patient, which we found in Tab 1, is 1.2, and the baseline activity for calculation purposes still remains as 11.9, and the minimum recommended activity is still 15 megabecquerels. This information is from table 2. Then using this information, we can substitute into the formula administered activity in becquerels is equal to baseline activity multiplied by multiple. That will give us 13.3 megabecquerels. From our calculation, we will then come to a point to say we can administer 13.3 megabecquerels. However, this activity will not be sufficient to give us good quality image. Hence, we have to administer the minimum prescribed activity, which in this case is 15 megabecquerels. The aim and objective of this study. The study investigated the types of pediatric diagnostic nuclear medicine studies and administered radiopharmaceutical activities at a tertiary hospital in South Africa, and compared the administered radiopharmaceutical activities with would-be administered radiopharmaceutical activities calculated using the European Association of Nuclear Medicine Dosage Card version 5.7.2016. Let's go to the materials. This was a retrospective study involving pediatric patients. Our inclusion criteria in this study were all pediatric patients from neonates to adolescents less than 1 year. We excluded pediatric patients from the study who had incomplete data in their records. From the records of these pediatric patients, we were able to extract weight, age, type of diagnostic nuclear medicine studies, and corresponding administered radiopharmaceutical studies for all studies undertaken from 2012 to 2015. The pediatric dosing guidelines used in the tertiary hospital were also documented. For each diagnostic nuclear medicine study conducted, corresponding administered radiopharmaceutical activities were calculated using the dosage card for each patient. Administered radiopharmaceutical activities were then calculated for each patient for the 2 dosing guidelines, that is the tertiary hospital guidelines and the European Association of Nuclear Medicine Dosage Card version 5.7.2016. Lastly, the range and the mean for administered radiopharmaceutical activities per kg were calculated for each nuclear medicine study based on the tertiary hospital guidelines and the European Association of Nuclear Medicine Dosage Card version 5.7.2016. The results of the study. In this study, it was established that the tertiary hospital used the Webster and BSA formulas. During the period of study from 2012 to 2016, there were 6 studies that were conducted. These were bone scans, renal scans, MIP scans, thyroid scans, HIDA scans, and reflex scans. Table 3 shows the range of administered radiopharmaceutical activities per kg calculated using the tertiary guidelines, which in this case were the Webster and the BSA formulas, versus values calculated using the European Association of Nuclear Medicine Dosage Card version 5.7.2016 for the same studies. For bone scans, the range was 44 versus 0.6. For HIDA scans, it was 13.8 versus 7.7. For the renal scans, it was 16 versus 2.0. For the thyroid scans, it was 6.1 versus 0.1. For the MIP scans, it was 15.2 versus 8.9. For the refresh scans, it was 3.0 versus 1.3. For the tertiary hospital guidelines, the large range shows the use of the BSA and the Webster formulas results in pediatric activities of the same age group being administered with varying activities compared to when using the European Association of Nuclear Medicine Dosage Card version 5.7.2016. Variation of administered radiopharmaceutical activities were previously found in a survey of 13 specialized North American pediatric hospitals by Travis and others, leading to mounted efforts aimed at reducing pediatric doses, which resulted in formulation of North American consensus guidelines for pediatric dosing. Travis and others attributed variations to use of pediatric dosing formulas, as was in the case in this hospital where they used the Webster and the BSA formulas. On the other hand, the small range in administered radiopharmaceuticals per kg when using the European Association of Nuclear Medicine Dosage Card can be attributed to standardization and several efforts to reduce pediatric doses, which saw them being harmonized with the North American consensus guidelines. Then we now proceed to analyze Figure 6 that shows administered activity per kg for various studies for the tertiary hospital and the European Association of Nuclear Medicine Dosage Card version 5.7. Administered radiopharmaceutical activities per kg based on Webster and BSA formulas are higher compared to the values calculated using the European Association of Nuclear Medicine Dosage Card version 5.7.2016. This can be seen in this Figure 6. For instance, the bone scans, the administered radiopharmaceutical activity per kg was 57.7 versus 9.6. For the thyroid scans, it was 7 versus 1.5. For the renal scans, it was 13.9 versus 3.2. For the HITA scans, it was 13.7 versus 5.8. For the MIP scans, it was 15.5 versus 9.8. And for the reflux scans, it was 2.1 versus 1.1. Previously, studies established that the use of Webster formula for older children leads to overestimation of administered radiopharmaceutical activities. This could possibly be the explanation for the very large variations of administered radiopharmaceutical activities per kg obtained using the tertiary guidelines compared to those calculated using the European Association of Nuclear Medicine Dosage Card version 5.7.2016. We would like to note that Clark's formula has been recommended over the Webster formula for calculating administered radiopharmaceutical activities for older children. The use of the European Association of Nuclear Medicine Dosage Card version 5.7.2016 has the advantage in that pediatric activities are based on it are not directly dependent on adult reference dose. The European Association of Nuclear Medicine Dosage Card relies on the baseline activities and the minimum activity for each study. One of the most important findings of this study is that the European Association of Nuclear Medicine Dosage Card version 5.7.2016 plays a significant role in A. reducing variability of administered radiopharmaceutical activities among pediatric patients of the same age group for the same study. B. Reducing administered radiopharmaceutical activities per kg. Administering low radiopharmaceutical activities to children is important because children are at higher risk of ionizing radiation compared to adults, since their organs are small and still growing. Lastly, they have a longer lifespan to manifest the stochastic effects of radiation. In conclusion, The use of the European Association of Nuclear Medicine Dosage Card version 5.7.2016 as a dosing guideline is recommended over the use of the Webster and the BSA formulas because it results in less radiopharmaceutical activities per kg being administered to the pediatric patient. Furthermore, it reduces variation of administered radiopharmaceutical activities among pediatric patients of the same group. For those who are interested in further reading, there are 6 references that can be consulted, which are presented here. Thank you.